there we go. Recording has started. If you want to admit everybody now, Jorge, please go right on ahead.
All right, here we go.
All righty. Good morning, everyone. As we're still waiting for a few people to join. My name is Ian Dunn. I am the chair of the Dosage Administration and Clinical Practice Committee. Welcome, everyone. I hope you had a good holiday season and are ready to start this new year fresh. If you wanted to bring up the slideshow, Dominic.
Yeah, I am going to bring up the one with the agenda first. Give me just a moment.
Okay.
And it should be working on it now. There we go. And there is the agenda. And then I'll switch over to your slides after this one, Ian.
Okay. Yeah, so here's our agenda for the day. It's just brief member introductions, get to know all of you guys that are going to be helping us out, your area of expertise, just what you have to provide, even if it's not, say, a professional level of expertise. Any expertise is appreciated, especially from our community. As well as we want to know why you're interested about dosage administration and clinical practice. So today we're going to go ahead and review our committee authority and purpose. We'll review and adopt our bylaws, and we'll look over our scope and work plan discussion. Alrighty, everyone. So welcome. This is the Dosage Administration Clinical Practice Committee. Thank you guys for attending today's meeting. This meeting serves as an orientation to the Dosage Administration and Clinical Practice Committee. It's an initial meeting for our committee members. And we do just want to inform you guys, if you decide to participate today, it does not obligate service long-term. It's just to help us develop this program. And you are willing, as much as you are willing to volunteer, we are willing to accept. All right, next slide. So the purpose of today's meeting is threefold. We wanted to explain the committee's purpose, authority, and scope of work, so everyone has a clear understanding of how this committee fits within the Medical Psilocybin program. Second, we will review and consider adoption of the committee bylaws, which establish how this committee operates. Third, we will provide space for questions and initial participation in committee decisions. This meeting is meant to be informative, transparent, and interactive. So we really just want to hear from you guys. Next slide. All right, and for any of you guys who have been in our committees, this is going to be a refresher, but for anyone that's new, committees operate in an advisory capacity. They do not replace the board, and they do not act independently of the board. One of the primary reasons committees exist is to allow people with relevant expertise to contribute meaningfully to program development. So even when they may not be able to serve on the board itself due to a real or perceived conflict of interest, we'll allow them to participate in the committees. That way we can still get their expert input, but without risking those conflict of interest things, because we have a conflict of interest free board. And committees support the board by expanding community input. They incorporate subject matter expertise, and they increase participation in the development of safe, effective, and evidence-informed policy. Next slide. All right, so this committee serves strictly in an advisory role to the Medical Psilocybin Advisory Board. While this meeting functions as an initial meeting for the committee, it is important to be very clear about authority and limitations. This committee may recommend policy and clinical guidance, including dosage ranges, administration protocols, and practice considerations. However, it does not make the final regulatory decisions. Final authority rests with the Medical Psilocybin Advisory Board for recommendations and ultimately with the Department Secretary for promulgating rules and regulations. Our role is to inform those decisions with sound clinical reasoning, scientific evidence, and careful consideration of safety. Next slide. Another reminder, committee service is voluntary, advisory, and non-exclusive. Members may serve on more than one committee, and participation is intended to be flexible while still meaningful. The goal is to bring together diverse expertise without creating unnecessary barriers to participation. And that's kind of the committee structure. So now let's look at the specifics for the Dosage Administration and Clinical Practice Committee. So the responsibilities of this committee are substantial and important, of course. This committee will recommend dosage ranges and administration protocols for medical psilocybin use, grounded in current scientific literature. We will also recommend guidance on therapeutic structures, including preparation, session duration, environmental conditions, and integration expectations. A key responsibility is analyzing the clinical research and available data to define clear dosage parameters, both minimum effective doses and maximum safety limits across different, therapeutic or consumer contexts. Next slide. So now that we've gotten the, explaining out of the way, if you wish to serve or participate in this committee, please raise your hand using the Teams function. He'll be bringing up a slide to explain how to do that. We're going to ask that you share your name, your role or any area of expertise, and your perspective or interest related to dosage administration and clinical practice.
Good morning, everybody. If you are interested in speaking and serving on the committee and introducing yourself, please go ahead and raise your hand. If you are on a computer, the hand icon is near the top of the Teams window and it says raise under the icon. If you are on the Teams app on a phone, please press the ellipses or the 3 dots in the menu, and then the hand icon will appear and you can select it. If you are joining through voice only on a phone, press *5 to raise or lower your hand.
Dr. Trish, your mic has been enabled. Please unmute yourself to speak.
Good morning. Hi, I'm Trish Singh, and I'm a LPCC in Albuquerque, New Mexico. I'm the owner of a New Awakening counseling agency serving court-appointed or court-mandated persons in Bernalillo County as a mental health and substance abuse clinic. My primary practice is in mental health and substance abuse. I have been studying and apprenticing in the psychedelic realm, and I'm also licensed in Colorado currently, and hoping to bring psychedelic assisted therapy to the population I work with here in Albuquerque, New Mexico. So I'm super honored and privileged to be here today and appreciate your time.
Thank you very much. Barry, your mic has been enabled. Please unmute yourself to speak.
Hello, my name is Barry Dunn. I'm one of the co-founders and president for Rio Grande Analytics. We're one of the cannabis testing labs here in New Mexico, but we've generated some preliminary data quantifying 6 different phosphorylated tryptamines, so we could help with dosage and making recommendations there. Of those tryptamines, psilocin, norpsilocin, and psilocybin are included. So I just wanted to let you know we're an analytical lab here that can offer support.
Thank you very much. Dr. Lida, your mic has been enabled. Please unmute yourself to speak.
Thank you so much for having me. I'm Dr. Lida Fatemi. I'm an internal medicine physician, worked at University of New Mexico for a decade as an academic hospitalist. So, I saw the really the worst pathologies you can see in the entire state and taught for a decade there, which with pleasure, and learned so much through our wonderful patients and the underserved community of New Mexico and the surrounding states. And now we have a hospice program. So I'm an end-of-life physician, and we also have our Conscious Physicians Psychedelics Academy, where we train facilitators at different doses for facilitation of psilocybin, and everything has been evidence-based, and it's going really well. It started in January. It's a 9-month program, but I have deep experience with this medicine for over a decade, both personally and also in facilitation in other countries. So it's a pleasure to be here, and it's truly a privilege to be part of this this moment in New Mexico history and for our country and really globally. Thank you for having me.
Thank you very much. Shane, your mic has been enabled. Please unmute yourself to speak.
All right, can you hear me?
Yes.
All right. First off, I'm having that same problem with chat, where it won't let me enter anything in the chat. But my name is Shane McDaniel. Currently, I'm a integration coach, and I'm also going to be hopefully entering into the cultivation world. My experience with it is pretty vast. I've experienced quite a bit with psychedelic assisted therapy from a healing point of view. Also, like I said, as a coach, I've assisted other people in their journeys. That's it.
Thank you very much. James, your mic has been enabled. Please unmute yourself to speak.
Morning, everyone. Ian, Dominic. My name is James Brown, and I am a doctor of pharmacy here in New Mexico. I'm out of UNM, and I'm very excited to be part of this committee. My expertise is I've been trained as a psilocybin facilitator in Oregon and done my training and everything there. I wanted to let everybody know that very recently I've been in agreement with Emerald Valley Institute, which is a training facility, to bring them to New Mexico. So we'll be bringing that institution and training program to New Mexico to offer that at a very cost-effective price. And I'm very excited to have that because the program has so much to offer New Mexico as a reference. And so we'll be here for you guys if you need any of that, as well as other New Mexicans. But more to come on that, but that's just new, exciting information. And I'm just very excited to be part of this committee because of what it does with our clinical research with this. I really want to focus on the preparation as well as the integration piece as well. All of this falls together. Thank you, everyone.
Thank you. Ellen, your mic has been enabled. Please unmute yourself to speak.
Good morning, everyone. My name is Joellen Schimmels, but I go by Ellen. I'm excited to be here. I'm a nurse practitioner in Albuquerque and have been working in mental health for almost 30 years. I'm trained in several therapeutic modalities and see mental health patients. I work primarily with PTSD, depression, anxiety, substance use disorder, OCD, and I work specifically with nurses and other healthcare workers, first responders, and veterans. I'm also a veteran myself. I served 23 years active duty in the Army. With deployments myself to Iraq and Afghanistan. And I'm a clinical professor at Emory University. So I work with the Emory Center for Psychedelics and Spirituality, and I teach in the psychiatric mental health nurse practitioner program there. And I own a mental health private practice here in Albuquerque. And I've been trained through the Integrative Psychiatry Institute. As a clinician, educator, and researcher, I'm very pleased to join this committee and thank you everyone for all the work that you've done so far. I'm so impressed with everything that's been happening in all the meetings. I'm particularly interested in how dosing and administration practices will interact with clinical context and with patient vulnerability and facilitator training, as I've heard some other people talk about. I'm looking forward to talking about how standards can be designed, really evolving with this evidence base. So I look forward to collaborating with this amazing interdisciplinary group to help shape these recommendations for the state. Thank you.
Thank you. Cameron, your mic has been enabled. Please unmute yourself to speak.
Hi, everyone. Can you hear me?
Yes.
Okay, great. Yeah, my name is Cameron Burgard. My degree is in biochemistry. I currently work as a laboratory scientist. I have many years of research experience delivering nanoparticle drug delivery for cancer. And I also have about 1.5 decades of dosing various psychedelics for all kinds of people. So Yeah, I've read just about every research paper there is to read. So I think my technical understanding of psychedelics is really good. And I'd like to lend that to everyone.
Thank you. Aaliyah, your mic has been enabled. Please unmute yourself to speak.
Okay. Hello, can you hear me?
Yes, we can.
Okay, took me a moment to find the unmute. My name is Aaliyah Doty. I'm a doctor of Oriental Medicine in Santa Fe, New Mexico. And I've been studying a lot about medical use of psychedelics, especially psilocybin, and I'm interested in potentially working with people in that arena, especially with microdosing and also working in collaboration with other healthcare providers and counselors, psychotherapists for working with fuller doses. And I do a lot with supporting people with nervous system regulation, and I'm very interested in trauma healing work. And so as a doctor of Oriental Medicine, we are in New Mexico, we're considered primary healthcare practitioners, primary healthcare doctors. And then the craniosacral therapy, I practice biodynamic craniosacral therapy, which is also really amazing work for helping people to very gently unwind what's held in the nervous system and body and energy bodies. So just interested in seeing and supporting this and moving forward in a great way to serve the broadest number of people in New Mexico and in a safe, supported way and an affordable way. Not sure what else to say.
Thank you very much. Julie, your mic has been enabled. Please unmute yourself to speak. Julie, your mic has been enabled. Please unmute yourself to speak. Okay. To the next person. Brett, your mic has been enabled. Please unmute yourself to speak.
Hey, good morning, everybody. Can you hear me okay?
Yes, we can.
Okay, great. Thank you guys. My name is Brett Phelps, and I am an attorney based in Las Vegas, New Mexico. I live in Mora, New Mexico. Have a lot of practice and experience with drug policy in general. Very interested in the nitty gritty of the regulations. Fairly familiar with the psychedelic realm, not at the scientific or practitioner level as some of y'all, but yeah, really love getting into the nitty gritty of the regulations and rules and how to fine tune that to make it as functional as possible, as accessible as possible, and as affordable as possible for as many of New Mexicans as we can. So happy to be here. Yeah, nice to meet all you guys and see y'all again that yeah, we've been working with a little bit. Thanks.
Thank you. Catherine, your mic has been enabled. Please unmute yourself to speak.
Good morning, everyone. My name is Catherine Warnock. I am located in Las Cruces, New Mexico. I am a licensed counselor and I have a private practice, Mariposa Counseling Center. I am trauma informed and I've been doing this work for about 4 years now. I have seen extreme success with psilocybin in particular. I'm very, very grateful to be here. I've been attending as many of these subcommittees as possible. I'd like to contribute in any way that I can. I'm very grateful to everybody here dedicating their time and effort. My focus is primarily on health equity, safety, and I really want to try to keep things in New Mexico. I'm really concerned about out-of-state interests coming in and the money leaving the state. But I'm here and I'll be participating as much as you allow me to. Thank you very much.
Thank you. Chris, your mic has been enabled. Please unmute yourself to speak.
Hello, everyone. Can you hear me?
Yes, we can.
Excellent. Hi, my name is Chris Piskuski. I'm an advisory board member and I'm the chair of the propagation committee. And I'll probably be involved pretty heavily with this committee as well in one capacity or another. And I just wanted to say good morning to everybody and I hope you have a good day. I can't stay long this morning, but I'll be around. Thank you.
Thank you. Gregory, your mic has been enabled. Please unmute yourself to speak.
Good morning. Happy to be here. My name is Gregory Evans. I am here. I am not a doctor. Pleased and humbled to be in this room. Thank you everyone for being here. I will be attending a lot of committees. I have a lot of interests, but related to dosage and administration, I'm very focused on monitoring how we define dosage, how we provide the analytics, and how that gets distributed on an education platform to the facilitators. Specifically, would love to get some time with you, Barry, to talk about what your company is looking to do for the analytics part of the compliance pipeline. I have a framework of dosage that I've been working on that basically levels everything out to a unified psilocin equivalency so that all disparate cultivars that have different potencies and different profiles and different alkaloids contained in them can be like dosed on an even platform. And then we can then look at the unique qualifying profiles that differentiate one cultivar to the next. I think that's an important aspect in harm reduction to make sure that we know what's going in a dose because there are so many variables on the recipient's side that we don't really have the ability to measure. And I want to make sure that we get as much science behind what's going in so that the psychologists and psychiatrists and therapists can provide the research of what's coming out, what the efficacy is of those things. I also want to stand up a conversation around what microdosing is, how it's applied, and hopefully provide the structure for a framework where we can allow certain types of tiered dosages to be executed in a non-clinical setting, e.g. take 2 of these and call me in the morning. Microdosing protocol should be done on a regular cadence 4-ish days a week, and people can't really go into a facility on that cadence. That is all.
Thank you. James, your mic has been enabled. Please unmute yourself to speak.
Hello and good morning, everybody. My name is James Halsove, and I'm from Arizona. I'm affiliated with the Arizona Department of Health Services, where I'm a biomedical research analyst. It's a pleasure to be with you all here today, and I think my biggest area of interest is how to go about the pre and post-session integration and preparation. I do deeply believe that medical psilocybin has the ability to help therapeutically However, I also think that there needs to be a really big importance for pre and post psychotherapy. So thank you very much for having me, and I'm very interested in learning from everybody.
Thank you. And that is everyone who has raised their hands. There's a few comments in the chat that I will read. Gregory Evans was just testing. Eric Baca has a extensive text here, message here about the formula to measure total consumable. I won't read that. Might take a bit of time, but folks, if you can't read that, we can make that available to you. This video will be uploaded. Shane McDaniel says, I did a restart and chat is working for now. And Deborah Thorne says, hello, everyone. I'm in between patients right now. My name is Dr. Deb Thorne, Doctor of Medical Science, Physician Associate, and Certified Integrative Psychiatry and Psychedelic Practitioner. I am representing the southern part of the state as a nonprofit and medical provider. I've been trained and have worked with psilocybin therapy for the past 5 years legally out of state and in Canada. Glad to be here and listening in on everyone's input towards regulations. I hope to add my acquired knowledge and experience towards this meaningful program. And we have one more hand up. Larry, your mic has been enabled. Please unmute yourself to speak.
Buenos dias, good morning. All right, sounds like you guys can hear me. My name is Larry de la Cruz. I am a U.S. Navy veteran. I am also a dispensary owner that focuses completely on removing stigmatization of these that a lot of people will call drugs, and it's not. It's simply an alternative medicine that can be used. So my focus with my businesses has always been education first. Education is always a must in order to treat people and start the lowest dose possible. So titration was always the word that I always used with individuals. I have been a cultivator for the last 5 years myself. And being a U.S. Navy veteran with PTSD, it has helped me tremendously. So to be anything part of this is immensely just puts a great smile on my face. So thank you for everything that you all are doing and this committee is doing, because these are medicines that could help individuals better than, I believe, better than pharmaceuticals, honestly, or in combination. Yeah, thank you so much for your time.
Thank you. Ian, that looks like that's everyone.
Well, perfect. So what we can go ahead and do now is go toward the bylaws, and then we can open up our initial, work plan discussion, what we want to move on first. But if you could open the bylaws for me, I have some trouble sharing my screen. Thank you. All right. If it will open on my side, that would be great. Cool. All right. So the name of this committee, obviously, the Dosage Administration Clinical Practice Committee. It's established and operates under the Medical Psilocybin Advisory Board. The purpose of this committee is to develop evidence-based, safety-focused recommendations related to psilocybin dosing, administration procedures, and clinical research and emerging best practices. So we also look at therapeutic structure guidance. We're going to recommend guidance on that therapeutic structure, including but not limited to their preparation requirements, how long a session is, the environmental conditions, and post-administration and integration expectations. Another thing we're going to have to do as a committee is analyze peer-reviewed clinical research, observational data, and real-world evidence to define clear dosage parameters. We also are going to need to do risk and safety assessments, look at each patient, see what our contraindications are, what are our adverse side effects, what is a disqualifying condition, things like that. Ongoing review and updates. So we need to establish and maintain a process for periodic review of emerging scientific literature. That just means if we make a dosage recommendation and then a brand new study comes out that contradicts us, well, we have to review that evidence, see if it was all it was stacked up to be, and then apply it to the program. So the committee membership is individuals with expertise in clinical practice, psychiatry, psychology, pharmacology, nursing, public health, or related disciplines, as well as public members where appropriate, and members shall serve at the pleasure of the board. The committee chair shall be appointed by the chair of the board. The chair is responsible for presiding over meetings, setting meeting agendas, ensuring timely development, and serving as the primary liaison. Then the meetings may be conducted virtually, in person, or in hybrid format. Usually I prefer Teams just for the fact that we are the 5th largest geographical state in the union. So trying to get people from all over to come to one physical location seems overly burdensome. So I just prefer to have it on Teams where anyone from all over the state can help out. I don't want to limit it to just Albuquerque having an input. I want all of the state. And then voting and recommendations. All of our things are basically a majority vote. All of our resolutions will be transmitted in writing to the board once passed. They are advisory in nature, and we do want that the committee members disclose any potential conflicts of interest. We're not saying that you are disqualified immediately, but we should be able to look at what your biases are and then analyze the decision as well, just to make sure that everything is above board. Not trying to disqualify anyone. I'm just trying to make sure that when we make this program, we're making it for the people of New Mexico. And these bylaws can be amended upon recommendation of the committee or at the board's discretion. So pretty basic standard stuff. I'll open discussion on it. If anyone has any questions, comments, concerns about the bylaws or would like to make amendments, please raise your hand now. Seeing no discussion, we will go ahead and move to a vote on the bylaws. So what I want you guys to go ahead and do is, if you are in favor of, if you had introduced yourself and are welcome to being a part of the committee, if you are in favor of adopting the bylaws, please use the Teams raise your hand function now.
Okay, and Ian, there are 15 people with their hands raised. If those
Perfect.
individuals could lower your hands at this time. Okay, and everyone's hands are lowered at this point, Ian.
All right, so anyone opposed, please raise your hands. With 15 yeses and 0 nos, the motion is passed and the bylaws are adopted. And now we can go ahead and move on to work plan discussion. So I want to hear from you guys. What is your priority? What do you want to focus on first? And that kind of thing. I'll go ahead and lead over to our committee members.
Ian, since we don't have any hands raised, I can go ahead and read some things in the chat then. Oh,
yeah,
actually, all right.
Oh, we got a hand. Go for it.
We do have a hand. All right, here we go. James, your mic has been enabled. Please unmute yourself to speak.
Thank you again. Some of the stuff I'd like to see us focus on as a committee, like you had alluded to, Ian, was there's a lot of research out there already that's set for dosings and times, right? So administration session times are going to be important, as well as the dose that is administered at that time. Some of the stuff too I'd like to see is who's going to be administering the dose. That's a big question that's out there. Can the patient do it? Can somebody else do it? In the medical model, you know, we're used to handing people stuff and administering stuff. Where in this model, a lot of it's self. The person self-administers and self does a lot. So just something to think about. But I'd like to really see us talk about, the dosing, the maximums, but really session times with dose will be important. And I'd really like to see us discuss that. And I think that Oregon is a little different than Colorado. So we want to just see what's out there in contrast, to see what the New Mexico model specifically will be. That's, I think, an important thing that people keep talking about is this is New Mexico. So we need to make sure this is New Mexico specific with the guidelines that are out there. But can we tailor it to a little bit more of New Mexico style? I think we can. So just a thought, an idea. And again, my disclosures would be that I have a nonprofit that is a veteran led because I am a veteran that's disabled. And I served 8 years in the Navy and continue to help vets. And I think this is a great thing. But that's my disclosures is that I have a nonprofit that's veteran and first responder based for psychedelics, as well as this school. I'm going to be bringing Emerald Valley Institute to New Mexico. It'll be a New Mexico-based program. And so I'm really excited to offer that to New Mexicans. But those are my 2 disclosures, just to make sure I'm up front. Thank you so much.
Thank you. Dr. Lida, your mic has been enabled. Please unmute yourself to speak.
Thank you so much. I have to second what James was saying about dosing and administration. And, because it's wildly different. This medicine is wildly different in its effects, and whether people are able to take it themselves versus having a guide. So based on dosage, if we're talking about microdosing, and there are many experts here on this committee talking about, the details of that. And I totally agree that, if you're given a regimen for a person who has treatment-resistant depression, let's say, in preparation to going into a macrodose session, then why shouldn't they be able to have that agency to take the medicine based on their needs and also the expertise of the guide with them in the preparatory phase, and then going into the macrodose with a guide in a safe setting, and afterwards, continuing on the microdosing regimen that works for the individual, meeting them where they're at. So I think, and I think, one of the things that I see be very effective for our New Mexico population, and yeah, our program was developed on the land here, which we're still grateful for, is people here tend to want more of that agency. And it's very possible, due to the intergenerational trauma that we see in the New Mexico population, people don't trust the colonized method of things, where even at UNM, we would see people not trust coming into the hospital because we, as physicians, as NPs, PAs, nurses, the medical industrial complex, we force people to take a particular dose of something, and you have to do it in a particular regimen. We train people, our facilitators are trained to meet people where they're at. This person may need a microdose once a week. They may need a microdose once a month. They may need a microdose for 4 days and then off for 3 days. So, and then the dosage matters, right? And so I think all of those things need to be discussed and considered in our population because of their special wants, and they should have agency in saying, hey, I think 50 milligrams is good for me, or somebody's saying, hey, I think at 200 milligrams I feel the effects of the medicine and I'm no longer suicidal. And then the macrodose journey is a whole different thing, but it's this medicine teaches us decentralization and connection with the sacred self and the sacred fungi, and the planet and earth medicine. And so I think it's great to be talking about all of that. At what level of the medicine, at what dosage do we need to have to be in person with someone, and at what dosage do we really not?
Thank you. And there are 4 more folks that I will get to. Shane, your mic has been enabled. Please unmute yourself to speak.
Yeah, thank you. Kind of want to hit a couple of different topics, and Dominic, I had already talked to you about this, so I understand it. With regard to microdosing, folks, it doesn't look like that's going to be able to happen because the way the bill is written, you have to be in a facility in a clinical setting to dose any dose, which pretty much means they will have to stay for a certain amount of time, right? Which means microdosing is probably not going to happen right away unless we can get somehow the authors of the bill to change the bill to allow it. It's not going to happen. Regarding dosing, is in Oregon and Colorado, two completely different models. Oregon, as I said in the last meeting, based their flood dose or macrodose or heroic dose on Terrence McKenna's minimum of 5 grams. And we all have discussed that kind of at length. That depends on, the strain, that depends, but that limiting it to 5 grams, I think is improper. For somebody who has experienced a lot of journeys, 5 grams probably isn't going to be enough. For somebody that may be a rookie and it's their first time, 5 grams probably is too much. But it also, depends on the person, weight, and that kind of stuff. But and then in Oregon, and then in Colorado, I think it's up to the provider or the person that is providing the medicine to determine what the dose should be. I think that's probably a lot better model as long as the people providing are experts at what they're doing. We don't want to see people getting too much. The other thing I would like to discuss is what this committee can do regarding required integration coaching. As somebody who is an integration coach, I came to that decision to be an integration coach because I didn't integrate properly on my first experience with ayahuasca, and I realized the importance of integration, preparation, and post. And I think we need to have some sort of regulation regarding that there needs to be a minimum amount of preparation integration and post integration, so that we can make sure that we are getting people the best outcome that they can get, right? If you just say you can come in and do the dose without integration, studies have shown that it is very ineffective, or at least in comparison to with integration. So I think we need to look at making sure that there is some minimum level of integration. And that's kind of where I stand on these things. Thanks.
Thank you. Ellen, your mic has been enabled. Please unmute yourself to speak.
Thank you again. I would reiterate what others have said about discussing dosing and the schedule variables. So not just about the dose, but the format. Are we looking at single session, stepped, repeated dosing, and then preparatory dosing? What does that all look like? I think timing and environments are really going to be crucial for this, and looking at what our parameters are for screening, for preparation and integration, as others have said. I think that this is never going to be a one-size-fits-all model. This has to be a very patient-centered approach. And this has to be really this is one component of a larger therapeutic system. So I think that whatever we do, allowing that there's going to be dosing ranges rather than fixed doses up front is something that we need to address. And if that's not possible, I would say that would be one of the first things we need to address. Clear criteria for what any kind of stepping is going to look like. And then obviously working with the training requirements, and then it might be that, having specific distinct protocols for different types of dosing sessions, and of course, ongoing data collection as we move forward with this. Thanks.
Thank you. Ian, I'm just going to read a few things in the chat right now. Let's see. Had an introduction by Ash Shelton, and let's see, by Cameron Burgard. I agree with Eric. All the information is correct. I would like to add that by saying that from the research, my own experience, I have found that there are many people's constitutions and or mental defenses do not always respond to suggested dosages. There are some people who are extremely sensitive who respond to dosages that shouldn't have any effect, probably due to placebo effect. I've also overseen beyond heroic dosages that have not produced little to no effect. For example, over 1K micrograms of LSD. Do not believe in standardized dosage, perhaps as a theoretical starting point, but I believe in practice, starting from 0 and titrating up for each individual is really important. It's very easy to give someone a standard dosage based on BMI and completely overwhelmed people. Let's see, then Zach Snyder had a question about types of treatments. Deborah Thorne says, as per the Oregon program, I think it's important for the participant to handle and prepare their medicines prior to taking it. Zach, will dosing address individuals that are self-administering under the care of a provider? Question. Matthew, I am Matthew. I reside in New Mexico. I'm here to participate as an observer. I do not own a business in relation. However, I'm an advocate and have cultural experiences as a native. Dominic added the bylaws into the chat. And then Zach Snyder, I think that dosing should apply to providers providing the medicine with guidelines for self-administration. Deborah Thorne, let's also consider the uniqueness of polymorphism in individuals who may not respond to the standard macrodose and thus make accommodations for it. Dr. Lita, is the dosage not at all negotiable? Question mark. That's not safe. Could we change that through the subcommittee? Question mark. Ash Shelton, absolutely pre and post integration is crucial. And then Dominic added, to be clear, one of the purposes of this committee is to look at dosage and administration. So the suggestions and comments being made and presented right now are those people are offering, and it will be up to this committee to discuss these issues and how administration will occur for the board to make recommendations. And Marcus, the bill says approved settings. Are we not looking to avoid the mistake made in Oregon? Catherine, for macrodosing, I practice updosing because each person is unique in their response to the medicine. From my experience over the years, no one specific dose works for everyone. Starting low and updosing to ego disillusion has worked very well for me. I found that most need 2.5 to 4 grams. Some people find this isn't enough. I think it's important to establish that by offering only 4 grams, first and a subsequent treatment can be arranged for higher doses are needed. And then let's go back to folks who have their hands raised, and I'll get back to the chat in just a bit. Barry, your mic has been enabled. Please unmute yourself to speak.
Hey, thank you very much. My questions circle around analytical capabilities and support from labs in New Mexico. When and how can we apply, and what will be required for the labs that will come in to support the dosing for clinical trials and things like that?
I just want to add something really, really quick. So some people were asking about the microdosing. So microdosing is allowed. What's not allowed is having them take that microdose at home. So what we could do is something like how they do what's it called? There are certain medications, I can't think of any that are a little less harmful right now but like chemotherapy, you go for a period to the hospital and then you leave. So what I'm thinking is we may not be able to do a microdose at home, but we may be able to do a microdose outpatient where you stop by, you get your medication, and then are discharged, assuming you have a ride. That's something we could look into considering. And then another thing was someone said this bill says approved settings are the bill says approved settings. Are we not looking to avoid that mistake made in Oregon? Well, we are. The mistake made in Oregon was, if you imagine like a strip mall with a building where they're all kind of attached, the Oregon law said that only if there was a psilocybin place in there, the entire thing, that entire strip mall would have had to be psilocybin. What we did was we said, okay, we have to approve settings, but we're not going to say that this building can only be for psilocybin. And I think that's how we avoided that mistake. Anyway, I'll yield back to the comments.
Thank you, Ian. Gregory, your mic has been enabled. Please unmute yourself to speak.
Oh man, I have so much to say. First, we need to adopt unified language and definitions around so many things. Soapbox number one, microdosing. What is a microdose? Do we have a definition written into law? Is it a good idea to write that into law? There's a lot of interpretation. I think we've all heard somebody, yeah, I just took a little microdose today. I'm tripping just a little bit, you know, and like, if you're feeling the effects of a microdose, it is 1,000, well, it is 90% too strong, right? So I think we really need to understand what that definition is, how it can be applied. If people are using the term microdose to say, you know, tripping just a little bit, like, then that's a different thing. It's like mini dosing. We need to get into that. We need standardized language, and we need to adhere to that language when writing it into law. I will offer a scientific value of a microdose in psilocin equivalency. A psilocin equivalency is going to be take into account your psilocybin and your psilocin in the biomass, and it is going to calculate that into what your body has potential to absorb as psilocin. There's like historic like analytics that measure things in psilocybin equivalency. That's one way to look at it, and I'm going to push for us to look at things in psilocin equivalency. 0.3 milligrams psilocin to 0.8 milligrams psilocin is a microdose. BMI doesn't need to be taken into account for this type of dosing. Those levels of psilocybin are less noticeable than any SRI that we are giving people en masse. This is a safe dosage that should be able to go home with people. In Oregon, there are cafes or yoga centers where you can go take a microdose, you stay for an hour, do a yoga class. This type of solution is a barrier to access. This does not create equity. This does not help Francine down on Country Road 75, who can't leave her house, doesn't like to do yoga, but definitely needs this medicine on a protocol basis and might not want to shatter their ego. There's so much in this medicine that does not require full ego dissolution. That is one thing that is valuable in a specific context. We cannot, if we are looking at this from perspective of equity, we cannot leave the furthest reaches of the people who need this the most out in the cold. Moving on. I'll read my comment so you can skip it. We absolutely need to take the concept of measuring biomass of full body fruits out of the conversation. When you say 5 grams of mushroom, you are saying 5 grams of variable, and that variable needs to be measured. We don't know. I can give you a pile of 5 grams and a pile of 5 grams, and one will make you trip so hard that you will not know who you are for the next 12 hours. And then another one, you could probably drive a car, you know, and because the biomass does not define what's being converted in your body, what you, it has no relevancy. Like, we could go into a gen bank sort of protocol where we like make a vat of 10,000, like, you know, 10,000 cultures that we freeze and remove and fruit those in highly defined conditions so they produce the exact same thing every single day, but with senescence and change in morphology, very like phenotype variations inside specific environments. We're going to have so much variation in our biomass that's produced and tested that we need to calculate it based on what is in, what it can be converted in the body, and what the potential actual dosage is from a psilocin equivalency perspective. I had one other thing, contradictions. I think that there needs to be room for people to, definitely needs to be room for people, for like highly trained, knowledgeable facilitators, prescribers, whoever is advising on medical consumption, to be able to be like, hey, cool, yeah, I see that you've been on like these SSRIs, you're coming off of these, you may need to like have a higher dose here or a lower dose here. When we get into the complexities of mini social lower and micro non subperceptual dosages, that becomes a little bit different than a conversation about trying to achieve ego dissolution. I do not like the term hero dose. I will I will stand for not using that. We just basically, we really, really, really need to get away from being like, yeah, 5 grams. Like, 5 grams of what, man? Tell me, 5 grams of what? And I will yield. Thank you.
Thank you. Ian, I'll read a few messages in the chat by James Brown. Will a facilitator be able to administer a session as an individual's residence? Question. It will be important to have access at home. Gregory also added, BMI is far less relevant than gut health. This needs a detailed study. Ellen says, yes, we have the opportunity here to define the setting. Deborah Thorne says, additionally, let's not enforce medication shaming and insist that those on a psychotropic medication such as Zoloft, Paxil go through a washout period, as this can cause profound destabilization. This is why medical screening is paramount. Aaliyah says, is it true that microdosing at home will not be legal under New Mexico law? If so, this must be changed. Gregory added, what is our definition of microdosing? Dr. Lita says, in our patient population, that doesn't really make sense. Ellen says, like the methadone clinic model, question mark, how inconvenient. Gregory added to that comment, please not. Cameron says, Aaliyah, that is the goal of decriminalization in New Mexico so that people can continue to practice at home without the fear of law enforcement officers. Greg Evans, I totally agree that the word that's missing is titration. Jesse says, not a microdose if you feel it. Zach added, a solution would be to have to be way, sorry, excuse me. A solution would be to have to be way we give the providers a process to administer outside of facility, have criteria that the providers stipulate. Let's see. Okay, let's go. I'll put a pause there, put a pin there, and then we'll go to Eric for public comment. Eric, your mic has been enabled. Please unmute yourself to speak. Eric, your mic has been enabled. Please unmute yourself to speak.
Hello, can you hear me?
Yes, we can.
Hello, my name's Eric Baca. I wanted to just kind of follow up on what Gregory was talking about. When we're all talking about the dosage and we are talking about the grams and how we're going to administer the dosage to people, I guess what my input would be the testing. We have to start somewhere, and testing is where we come to a agreed upon, like he was saying, the variation between different fruit bodies and the content of psilocybin in those fruit bodies. So telling people to take a gram of this or a gram of that, it doesn't really work. What would be a better method would be to test the fruit bodies and determine what the percentage or content of the psychoactive ingredient, or what we're actually here for, which would be psilocybin, the medical program of psilocybin. So once that's determined, then there is a formula to, I guess, to calculate what the conversion of the actual active compound in the body, which would be psilocin. So the standard that we have on that should be set according to something that we can apply across the board. That was my only input that I really wanted to give. And so the conversion I did put into the chat, people can look it over, and that we have to be able to agree on absolutes. So whether or not a person can handle that much of a dosage or not will have to be determined by a physician and the individual themselves. Also, some of these other tryptamine compounds that are in fruit bodies also play a role in the effect or the experience. And so, but the superseding psychoactive compound is psilocybin, and so, and then, is psilocin. So those things all need to be taken into consideration when setting dosage guidelines, and not fruit body weight or because for the general consensus, some people will say 100 milligrams of fruit bodies is a microdose, but what is the percentage of psilocin in that 100 milligrams or gram? And there are conversion rates for that, and you can determine all those things through lab testing. So once we have that, and we have the lab testing, and we all have a set formula that things can be measured by, then we can start talking about what is the dosage that's adequate for an individual and what isn't. And until we get there, then we can't really do that. So that's my input, and thank you guys for listening.
Thank you. Aaliyah, your mic has been enabled. Please unmute yourself to speak.
Hi. With microdosing, you do not feel high from it if it's a true microdose. You don't have hallucinations. You're fully functional to be able to do whatever you're normally doing in your life. It's not true that you don't feel anything. You can feel uplifted. You can feel your nervous system be calmer, your mind be calmer and clearer. You can have enhanced awareness of things. Yet you're fully functional. In fact, according to the research, you're even can be a lot more functional in anything that you're doing in your life, and have more vitality, more creative energy for anything that you're doing in your life. I think it would be ridiculous to require people to go into a clinic to receive a microdose if it's a true microdose. And it would be more expensive for anybody that is wanting to do microdosing. You can have tremendous results from microdosing for all kinds of things in your life, according to lots and lots of research. It can help to create new neural pathways in your brain. It can help to heal your nervous system, and it can enhance your memory. It can uplift your energy and mood. It can help to clear inflammation. It can help to enhance your consciousness of a higher level of consciousness. And there's absolutely no reason for people to have to go into a clinic to get a microdose. And it would just be, I mean, then you'd have to pay a clinic to get a microdose, for somebody to serve you with a microdose. And there's no reason to have a chauffeur to take you home. I mean, it's ridiculous. You don't have to do that with marijuana. Why would you have to do that with a microdose where you're feeling even less than you do with marijuana? I think that's a ridiculous law. It's very limiting. It would be very limiting for the benefits for a vast number of people in New Mexico. And it's really upsetting to me to hear that that's the law. And that really needs to be changed ASAP.
I do just want to add, it's also like not my opinion that they should have to go to outpatient. That was just my solution that would be compliant with the law. I'm just trying to follow what they've given us to do. The legislature has been incredibly kind in delegating legislative authority to this board. So I don't want to be disrespectful and say, hey, we're just going to completely ignore what you guys wrote. And also unlawful. But I want to make the record clear. I do stand behind being able to have a microdose at home. I just agree with that point. However, under the current law, that's where the complications come in. I just wanted to it to be understood that I'm not just if that wasn't in the law, I wouldn't be well, they still have to go to an outpatient. I'm just trying to come up with solutions that are within SB 219.
And good morning, everybody. This is Dominic again, and I just want to be clear. The bill itself does not exclude microdosing. Some of the comments kind of being made, I think we're getting down the wrong path and in the wrong way. It also does not exclude individuals using it home. What it does exclude is that it excludes people using it outside of a therapeutic or medicinal setting, and that's the approved setting. And so one of the things that we have been looking at as far as, for example, with hospice, and I've actually been on the record, in fact, I discussed this in a podcast just yesterday, that some of the things we're looking at is how do we do that? We cannot expect a patient who is not ambulatory, who is not able to move, and has to stay in their bed. We can't expect them to move not only to 10 or 20 or 100 miles down the road to go to a clinic, but or just even down the hallway sometimes. We have to figure out ways of doing that. That can be done as facilitation. So some of the things we've talked about is, will there be ways for the facilitators to visit in the home to be able to do dosing? We understand that creates an issue when people are talking about microdose. I will be very clear during, and people can go back and look at what was occurring at the Roundhouse in the last session. They have all of the videos of the committee meetings and everything else in there. The way that the bill was presented was doing this in clinical settings, therapeutic settings, and doing this with the model of the integrative therapy before, the journey, and then integrative therapy afterwards. So it did not come in with regard to that. We are trying to figure out, and that's what this committee in part is about, is how do we take some of these opportunities for figuring out how do we serve those individuals to be able, who cannot leave home, how do we serve them in a way that's going to work within the framework of the statute? The statute does say it has to be an approved setting. There are different ways we could potentially define that, which could include making sure that there is that trained, certified individual there to assist with the dosing, make sure the protocol is followed. This is not a decriminalization bill, and we need to make sure that people are understanding it is not a decriminalization bill. It is a bill for medical use only. That means it has to be done in a therapeutic session. Can that therapeutic session potentially be in someone's home? Yes, but what are those conditions going to be? That is a part of what this group is about, of How do we set up those requirements, those protocols in order to do it within the statute? And my concern is just everyone, we're seeing a lot of comments in here about we have to do this, we have to do this. There are things that we're going to try to do as best we can to serve as many patients as possible, but it has to be done within the statute. And I'm also going to recommend, because we do have a time limit with a hard stop at 11 o'clock, and there are a lot of people I know who want to speak on this, I'm going to recommend that we do set a time limit. Ian, what do you think would be appropriate? And this is just, of course, as people talk, if afterwards we have additional time, people can also speak again at that point. But there are a lot of people who want to get their thoughts out, and we want to make sure this is a place for that. But I would recommend, say, a 3-minute limit, which is what we usually do during public comments during the meeting. I see Ian is nodding his head. And again, we'll go through the list, and then once we reach to the end, if people would like to speak again, we can call on people again, so that we can go ahead and do that. Okay. So thank you, everybody. And with that, I'll turn it back over to Jorge for the next individual. And again, just because there's amount of time, we want to make sure the people who have their hands up to speak. So please go ahead, read through what is in the comments. That will make sure that's included in as far as once the meeting is over, people can still access them for a little while, so that if people have ideas and items like that. So anyway, in that case, Jorge, if you'll go on to the next person.
Brett, your mic has been enabled. Please unmute yourself to speak.
All right, thank you guys. Yeah, having some good discussion here. Yeah, I think one element of this, I think Dominic nailed a lot of what I was going to say about the approved setting is really all that's in the law, and what that means is going to be up to the board and the department. And I think it's okay for Ian, if you feel strongly about something, I think there's room for interpretation on those kind of things, that you don't have to necessarily withhold your own beliefs as the chairman of the board, and ultimately if DOH doesn't like it, then they don't have to accept that either, and if the legislature doesn't like what DOH comes up with, then they don't, they can always modify the law. But I think you're on the right track of how do we make this as expansive as possible. And one angle on this that we talked a lot about in another committee is the use of telemedicine. And how that may be able to help facilitate some of these issues that people are bringing up, in the context of people being able to, use the medicine at home. I think allowing, particularly in the end-of-life care or hospice, for things to be done at home as an approved setting. That's a very broad definition that we're going to have to define. And I think the access we have to telemedicine, the state has done a lot with that in the last several years since COVID, and really understands how to use that. So I just would recommend that. And I think given practitioners a lot of discretion in terms of dosage and those type of things, that's the kind of thing that is probably best handled between a doctor and patient, or provider and patient. So I would just advise to not be too strict in terms of what the dosage requirements through the regulations look like. But yeah, thanks again. I appreciate all the conversation on this. And Dominic, thanks for keeping us heading in the right direction.
Thank you. Cameron, your mic has been enabled. Please unmute yourself. Excuse me, please unmute yourself to speak.
All right. Hi, everybody again. I can't agree more with Greg Evans that we really need to move away from this language of microdose, macrodose, heroic dose. Those are all based on individual subjective measurements. The word that we're really looking for is titration, which means anything just above 0 all the way up to, grams of active compound or metabolize psilocybin. So with titration, I think what would be most beneficial is before we try to intend giving anyone like a real active dose, I think we should work them up from zero, titrate them up to where we find that activity line for each individual patient. Once we do that, then the true like active dose can be determined for that specific patient. I also think that there might be room for extraction. If there is mushroom extraction, then we can actually dose out psilocin or psilocybin, whichever we can extract out, and that person's dosage could be essentially measured for each person. And that way, even if you grind up the mushroom, there could still potentially be hotspots, depending on the size of the grind. I think in several patents that I've read through about extraction, the the particle size was like 40 micron. So we're gonna have to like require some specific equipment for the grinding just to avoid hotspots, because in the cap you have a higher density of psilocin and psilocybin versus the stem. Also the other alkaloids that produce the entourage effect, those are in different amounts in the cap versus the stem. I would also like to say that, you know, to everyone that is talking about microdosing and even the larger dose effects, all of the microdosing research, all of that data was supplied by people themselves. It was not recorded in a laboratory setting. That data was self-reported data. So there's a lot of subjective discrepancies within microdosing research. That's not to say that the effects of neurogenesis don't exist. A lot of the
Cameron, you have 30 seconds.
Okay, yeah, I do believe that neurogenesis is a part of it, but a lot of that research is in vitro and animal model research. And the in vitro is with human 5-HT2A receptors. So we still have yet to see the effect of the neurogenesis that is present with all the psychedelics, but it is there.
Thank you, Cameron. James Brown, your mic has been enabled. Please unmute yourself to speak.
Thank you, sir. Hey, a couple of topics here that we haven't talked about yet would be the inclusion criteria or exclusion criteria that Ian brought up earlier. I think that's going to be important to look at as a group. A lot of literature out there, but what really, you know, a lot of stuff with the SSRIs, the MOAs, that stuff right now is being looked at as, you know, do they really need to taper down, or can you dose those and keep the patient on those if they're on that polypharmacy style? Something to look at and talk about with our group. Also, something to look at is those informed consents. I think it's going to be important that, you know, we look at the different settings, and then what consent, is it a one for all, or is there different consents for the different settings? I'd like to talk about access as well. As we push these models, one of the big things in Oregon is sometimes the patients have to show up and get their dose at the center. And it's very hard for those patients to access the centers and get there all the time. So something to look at is our therapy plans. And I really think that we need to be specific in our therapy plans for our different settings and really look at what that entails, what does the literature say, but also what can we do to allow access here in New Mexico with our therapy plans. And that'll include the dosing and where it can happen and all that stuff. But definitely we need to look at things like what's happening with the cannabis. As the centers open up, and there's so many centers in the various communities in New Mexico are going to be very different, rural versus industrial. If we go to Albuquerque, the centers are going to be maybe abundant. If we go rural, Clovis, Farmington, Las Cruces, how many centers really going to happen, and how much access can happen there? So something to think about. And
James,
also,
you have 1 minute. You have 1
Thank you,
minute,
sir.
James.
And capturing this data will be important for this group to think about, and everything that we do with this data, and how do we keep the process going. And I like to talk about that with you guys too, is with that periodic review. How often do we want to review everything? Literature is coming out all the time. And how viable is that literature? Is there that bias in there? Is that written by somebody's being sponsored by somebody else? So really look at that, and how often do we look at that? Periodic review will be important, as well as just getting together. I'm so excited again. Thank you, Ian and Dominic. Thank you, Ian, for heading this up. I really appreciate you. And that'll be it. Thank you.
Thank you. Cameron, your mic has been enabled. Please unmute yourself to speak.
Yeah, I just wanted to touch on some concerns about being able to prescribe and this stuff to where people could take it home. I know that there was a big concern in the medical cannabis program that people outside of the people that were prescribed were getting a hold of the medication. So if people are supervised when they're taking the medication, you could eliminate this potential problem of spread that is beyond who is intended to take the medication. I would also like to say that the approved settings probably need to be taken into account with a medical perspective, in that if we don't know how somebody responds to this stuff, I think maybe for the first couple of sessions that should be done maybe within city limits, to where if somebody does have a problem, that the paramedics could reach you and treat this particular person until we know how they respond to the medication. I think that can't be overstated, as I've seen benzodiazepines have been pretty important for people that are experiencing adverse effects or agitated states that you can't reason them out of. And obviously we wouldn't be able to give them benzodiazepines, but in the ED, the emergency room, that is part of their protocol, is administering benzodiazepines. So I think we really need to consider
Cameron, you have 1 minute.
Okay. But yeah, that was my point. My whole point was knowing how your who you're treating is going to respond.
Thank you. Patricia, your mic has been enabled. Please unmute yourself to speak.
Thank you. My name is Patricia Stellamar. Sorry I missed the introductions, but I wanted to just kind of add to a couple of other comments that were made. Specific to the dosage considerations, like to be the most efficacious, I don't think that this can or should be mandated by the government in this program. I think, like someone else had mentioned, really having that be a decision between the provider and the patient in a way, just having some agency, we can have guidelines. But I think being overly prescriptive about you start here, you go here, you go here, like it's not quite like that in my experience. And another thing I wanted to mention is that multiple people mentioned BMI, and I'm not a doctor or a scientist, but in my experience working with this medicine with myself and others, BMI has not correlated with impacts of dosage. I've seen large men and small women taking the same batch, same setting, same preparation, same experience, like with the same dose very differently. And so I think a lot of that is like close observation. Also, like Gregory and someone else had mentioned, really starting from the point of zero and working up, very closely with that person and whatever that setting looks like. I think it would be very cost prohibitive to only make that step up process be in medical settings. But that's just my opinion from my experience. I think the home setting is super important, not only for microdosing, but as an available option for those that are not in favor of Western medicine and have not, where that has failed them and they're seeking this. Obviously, there's also a ton of people that only want to have this, administered by doctors and medical providers too. So just kind of adding to that echo of considering the home as a clinical setting and then defining how that can be done in the ways that, we feel comfortable with as a community, in ways that also incorporate the grandma in the rural place or people that have mobility issues.
Patricia, you have 1 minute remaining.
Thank you. I also want to agree with a comment that Aaliyah had made regarding just the protocols being overly cumbersome in cost and limiting access. Just speaking with some places that I've called in Colorado, I've just found it a little bit obscene, some of the requirements there that are reasons why it makes it incredibly costly. So I think just it's important to have parameters and guidelines, but also having those be adaptable depending on, the circumstance and taking into account safety. Thank you.
Thank you. Ian, did you want to, you have your hand raised. You are the chair, so.
Yeah, I just wanted to add on to that. She had mentioned that dosage should not be prescriptive, and I couldn't agree more. What I had originally kind of been thinking about, not official or anything, just how I had envisioned it. So we would have a microdose tier that would be like, I don't know, I'll throw out a number, less than a gram, assuming that it was impacted by BMI. And then we'll have another tier that'll go low therapeutic, that'll be like 1 to 3. Then medium therapeutic would be 3 to 6, and then 6 and above would be high. I don't think we should tell them you should prescribe this dose. I think we should give them a range, but then we can add specific safety mechanisms like additional screening for particular dosage categories. That way we're not being overly burdensome for like a microdose while still working within the confines of the law.
Thank you, Ian. Ian, also just want to inform you that there are a lot of comments in the chat. I'm not going to read them all for sake of time, but we will download those and include those in the minutes, and we'll continue on with the speakers. Dan, your mic has been enabled. Please unmute yourself to speak.
Hello again, everybody. Dan from Oregon, laboratory here in Oregon. I really feel like people go in, at least here in Oregon and Colorado, for certain, they're seeking certain relief, and the relief requires different dosages for different types of relief. So starting people at the bare minimum and working them up, I don't feel that's beneficial. I also feel like if you guys are going to do a medical model, and I heard the speaker earlier about the cannabis, how medical, everybody was worried about it getting into the hands of people that are not, do not have a prescription. But I hate to say it, but I have a feeling that opioids and prescription drugs end up in the hands of people that do not have a prescription. So I would, I really believe that microdoses, 1 to 2 milligrams, total equivalent psilocybin, should be able to be sent home with the people. You know, there you can put things in place where they can sign paperwork and do all whatever they need to do and be informed that, you know, you cannot share. And if you are caught sharing or whatever, then you could be held liable. That's basically it. I really feel like microdoses is subperceptual dose, and I do lean towards, if somebody is new to this, maybe have 1 or 2 microdose sessions in-house, just to make everybody feel at ease. But then at that point, no side effects, send them home with some microdoses. I do not recommend sending people home with anything more than a microdose. Set and setting and purpose is all part of it. Sorry. Thank you.
Thank you. Denali, your mic has been enabled. Please unmute yourself to speak.
Good morning, everyone. Thank you, Chair Dunn, for facilitating this important conversation. I jumped in a little bit late, and so I'm sorry if others have mentioned this consideration when it comes to approved settings. But I wanted to zoom out a little bit and talk about the room for flexibility that exists in New Mexico, just given the model that we've adopted. Both Oregon and Colorado are service center models. That means that the agency is licensing a brick and mortar space. That's not the model that New Mexico adopted, right? Our authorization is to providers and healthcare entities, which then I think, you know, we'd really be missing an opportunity if we don't take advantage of the flexibility that allows. And it's really a demonstration of our values of trusting, supervising care providers to make the best decisions for the people in their care. I want to mention, you know, I echo everything that's been said about in-home accessibility. Another option, again, that is available to us outside of a service center model like Oregon and Colorado is considering outdoor settings. And I think, you know, in a state like New Mexico, where we are just blessed to be in such a beautiful state with so many beautiful and amazing places to explore in the natural world. I mean, anyone who's had an experience in nature knows that, you know, some of the deepest healing is really possible. And I think that there are ways for us to create the kind of safety that we need to within a retreat style or temporary approval for a nature-based healing experience.
Denali, you have 1 minute.
Another speaker mentioned, you know, maybe limiting things to city limits. I think we can be a little bit more expansive to that and still get to what that speaker was saying about, you know, accessibility and closeness of EMS and other safety considerations. You know, how much control can we make sure that people have over the environment and, you know, public access, these kinds of things. So eager to be in continued conversation about the wide variety of opportunities that are available to us here.
Thank you. James Brown, your mic has been enabled. Please unmute yourself to speak.
Thank you again, everyone. And just probably last comments of the day. I'd like to talk a little bit about that telehealth option. I really think that we need to be utilizing that. I think that was a great point earlier, and it's also been discussed prior. I think our virtual access is going to be important, and allowing that virtual access with those consents, it'll be very important for us to do because this again is rural, and you know, we don't want to fail with this. We want to be very successful with our access to our people. We deserve that, and we need that here in New Mexico. We're very limited in providers, and as we teach and train these people to become facilitators, they need to be aware of what, what's out there for them. And access is going to be a big, again, I can't end enough with that. But I think, again, we look at telehealth as well as my last piece is that administration sessions. It hasn't been talked about very much yet. And I want to bring that up to everybody. My best experiences and what I've been learning is that hands-off method. Individual containers are very important for individuals to heal and self-grow. And so with those containers, I think with the administration sessions, when we look at hands-off type of techniques to help them. And so that'll be a great discussion point is what do we do during the administration sessions and what is allowed and what's not allowed and what consents need to be done prior to that during that preparation phase. Getting that person or individual ready for their experience and their growth and their healing. It's going to require a lot of time and effort, but also it's going to see during that administration, what's allowed during it. There's a lot of new techniques and a lot of research out there about
James, you have 1 minute.
Different things or activities during the administration session. I think that's a sticky point. So we need to really open that up. I think we need to be very broad and vague to when somebody is doing their administration session that they're allowed to have different experiences and not limit them. So let's look at that. So thank you again, everybody.
Thank you. James Hosobe, your mic has been enabled. Please unmute yourself to speak.
Excellent. Thank you. Can you guys hear me okay?
Yes, we can.
Okay, thank you. I'd just like to touch on something I don't think has been spoken about yet, but after a personal GI visit for a procedure, I think we should really model the post-psilocybin decision-making safeguards in relative to really informing and educating the patients to be explicit, to not make any major decisions or sign important documents for a defined period post procedure, or excuse me, this medical psilocybin session. I deeply believe that altered states from psilocybin, even when therapeutic, can impair judgment, suggestibility, and even emotional regulation. So similar, I think, with the post-session protections should be built into the clinical practice guidelines. I really appreciate all the comments, and I'm really excited how this all progresses. Thank you for hearing me out.
Thank you. And Ian, those are all the hands.
Alrighty, guys. So thank you so much for sharing. One thing I kind of heard multiple times was that the dosage, oh my God, my brain just blanked. Anyway, that the administration could be done by having the facilitator go to their home. I think if we defined an approved setting as with a facilitator, that would pass the litmus test of, okay, is this medical and therapeutic and with a facilitator as the current law requires? Because the approved setting isn't the only part of the bill that kind of makes at home a little bit more difficult. So for instance, the bill requires that we have an administration and a preparation and administration and an integration session, which if you're having them do multiple doses throughout the week, that could become a little bit more difficult. Working within the confines of the law, though, I think if we had a facilitator be able to go to people's houses, that would A, solve our hospice problem. It would B, allow people who are maybe unable to leave their home for whatever reason to still have access to treatment, and would actually be a legally defensible approved setting versus just a home in and of itself. I have been working with the legislature to try to a couple of different representatives to try and see if we can get microdosing done. I am going to let you guys know they are very concerned that this program is going to turn into recreational use. So that's kind of what they've been letting me know. And so that microdose might be a little bit harder until we have, because I want you guys to remember that this was the first law that was passed for New Mexico on psilocybin. Like the medical cannabis program, it had an original law and then was greatly expanded in 2019. So just like that, we may need to practice some of the, more burdensome options, like having a facilitator go to your house. But if that turns out to be successful, um, once the microdose in an outpatient clinic is successful, then we are able to say, okay, maybe we can just have it at home. But right now, there's so little data on widespread access and allowing access to psilocybin that we don't want to create a bunch of problems allowing people to take it home, and then all of a sudden there's a problem in the program or something happens or life comes at you. And I just want to make sure that we are protected on all sides, because I believe this is just the start of the program. This is in my view, this is the most restrictive the program will be. It will open with time, but we have to let the legislature see how this program is working, where the flaws are. We may be able to identify them now. They like a little bit more hard evidence. So I just want y'all to keep your minds open. This isn't the final, I mean, it is the law, but this is not, I have serious doubts that this will be the final law on the issue.
Ian, we do have one hand raised, so whenever you're ready, just let me know.
Go for it.
Okay. Jesse, your mic has been enabled. Please unmute yourself to speak.
Good morning. Just to touch on this, the therapy, there's a company called Psychedelic Passage out of Colorado, and the way they do it is a 5-week session, 2 weeks with a therapist. They'll first analyze your intention and what you're trying to help yourself with, and then there's a week of ceremony, and then a 2-week integration after that. And I think that's kind of a great model to maybe adopt or at least look into. I was talking to them years ago about doing a journey with them, and they told me that they were actually interested in branching off into New Mexico. So that might be something that we want to, work with and hopefully get some resources from them. That's it. Thank you.
Thank you.
Alrighty, and now that our time is almost up, we have about 15 minutes left. I'm going to go ahead and summarize the orders of the day. We passed our bylaws and had some great discussion about microdosing, about facilitation, approved settings. It has been a very productive conversation. I expect us to meet every 2 weeks. However, one thing I was looking into, if you guys are interested, is having a joint committee meeting with the Patient Qualification and Safety Committee. That would allow us to do all of the preparation stuff. So if they have to do any preparation documents, we can look at the Patient Qualification and Safety Committee's exclusion criteria, and then we can look at our dosage criteria, and we can kind of blend them to make the preparation session requirements. So that's what I have planned. So let me see what dates work for y'all. I know I'm usually pretty good on Friday mornings. Otherwise, the afternoon is probably the best for me, but I will let you guys decide.
Ian, I just looking and with some of the items here, I would recommend Friday the 30th at this point in time does not have other meetings scheduled at this point. And that would be basically 2 weeks and then moving it to Friday rather than Wednesday.
Okay, cool.
So
All right.
I would recommend
yeah,
say from 1 to 3 on Friday the 30th.
I would be okay with that. If you guys want to throw up a quick thumbs up if you guys are good, or a yes in chat works. Cool.
Okay, I'm seeing the majority of yes. And just as a reminder, you know, we're never going to be able to have schedules for everybody that's going to work for every single person that is here. And just to answer another question in there about the subsequent meetings, what we are doing is we are posting that on the Medical Psilocybin page in the announcements section. And so we're posting those. We are batching them. And so you'll actually see the notice for the next round of meetings coming out. We were actually waiting for this meeting to finish, so it'll be coming out either later today or tomorrow on that announcement page. And then we also do send them out through the update email list, which if you're interested in signing up for it, just so everybody knows, you go to the www.nmhealth.org page, and in the upper right-hand area, you click on the sign up for e-news. Once you click on there, you just complete your basic information. And then you can select the Medical Psilocybin program checkbox. You can also check any other topics that you may be interested in to get those updates from the department. And then just make sure you click sign up, the big yellowish orange box at the bottom. And sometimes, depending on your own system, you may have to confirm you are not a robot. And then we will also be sending it out through there, again, like I said, in the next couple of days. But then we do have that, and we'll be sending that out. Part of the reason we're doing that is because many people are involved in multiple committees. And so we're going to be batching them every week or so, simply so that we do not overwhelm email boxes with lots of emails. Because especially for some of the board members who are involved in all of the committees, there are 7 committees plus the board itself, plus other announcements that we do send out through there occasionally to update people. So we don't want to just overburden people. So this right now at this point is our best method. So that's what we're essentially doing. And then the other aspect, just in case anybody has additional information or wants to check in what the links are for the website, is medical.psilocybin@doh.nm.gov. And the program website, which is where the announcements are, it's on that first page. And then you just scroll down a little bit and it shows the announcements. In fact, I'll go ahead and let me share just so everyone can actually see it. Pardon me for just a moment while I switch to actually showing that screen. So for example, this one shows the current list and the current, for example, all the committee dates and times. This is for the ones that are going on right now. And so there will be a new announcement here in the next day or two that will show the next round of announcements. And just in case, so everybody has it in the chat, I am putting that particular page in the chat directly. So there is a link to that page. Okay, and I think that's all I have. Oh, the other item, just to let everybody know, is while we do post the recordings onto the Psilocybin Advisory Board, and then they go onto the meeting records page. So just to give an example, and then the meetings that happened last year, which were in December, and they did post the first one on January 16th for the upcoming board meeting on this Friday. But then 26th, they're already starting to post some of those documents and the recordings. It does take between the review that it has to go through internally in case there's anything such as inappropriate language or anything else. And then what we do is that gets posted. It does take between 5 to 10 business days, so please be patient. It is a large volume of items being generated by all of these different committees, but we are adding all of those items in. So thank you very much, everyone, and I'll go back to you, Ian.
Ian, there's one hand raised.
Sure. Lady de la Cruz.
Larry, your mic has been enabled. Please unmute yourself to speak.
Hi, can you guys hear me?
Yes, we can.
Okay. I just want to say thank you so much for this. It's been so educational, so helpful. Just knowing that this exists, just, I don't know, puts a light in my head and just the potential to help as many people as possible, to show them that this is more than just, this is for medicinal purposes. And yes, so if it goes recreational, then fine, maybe, but alternatively, this is a medicine that can help people enhance their lives. So thank you all for everything, all the comments. Yeah, hope you guys have a blessed day.
Thank you. That's all, Ian.
Alrighty, well, I guess I will call this meeting adjourned. I am so happy that all of you were able to join. I wish you guys a great rest of your January, and I will see you at the end.
Thank you, everybody.